joint replacements and amputations. Our unit objectives are to apply the core knowledge of normal anatomy and physiology to the management of patients with joint replacements and amputations, to discuss the indications and contraindications for joint replacement surgery, discuss postoperative care, potential complications of patients with joint replacements and amputations. So our first thing we're going to talk about is total hip replacements. So here's a picture of a normal hip joint. You can see the acetabulum, the cup is nice and smooth inside, and the tendons and cartilage and everything are nice and intact. Now this is a diseased hip joint. You can see deterioration of the acetabulum, deterioration of the head of the femur. And one of the most common causes of needs for total hip replacement is degenerative joint disease, osteoarthritis. And then when patients have pain that is not responding to conservative treatments like NSAIDs for 6 months or more, prednisones, steroid injections, inability to work, sleep, move due to the pain. A previous hip replacement where the prosthesis has loosened, which is why they want patients to wait as long as possible before they have a hip replacement, so they don't need to go back at a very elderly age and try to get that hardware replaced. Some hip fractures, some hip joint tumors can be benefited by a total hip replacement. Contraindications would be a current hip infection, poor skin coverage around the hip so that the skin incision will not heal, paralysis of some of your muscles, severe peripheral vascular disease where healing is going to be impaired, neuropathies, severe limiting mental dysfunction. There are a lot of protocols that patients have to follow after a total hip replacement, and if mentally, cognitively, they are not able to conform to those protocols and restrictions, it may be contraindicated for them. Morbid obesity, which is why they will have patients lose weight before they have their hip replacement, because that excess weight on the prosthesis can cause it to dislodge. And severe osteoporosis, because if the bone is weak, then it could crumble or crack from the stress of that prosthesis being applied, or once it's done, to be ambulated on and bearing weight. So the procedure is to remove the head of the femur, and they kind of ream out the acetabulum to smooth it out. Then they put a new cup into the acetabulum. They put a new head of the femur with a shaft that goes down the shaft of the femur, which is why the osteoporosis would be a contraindicating factor. And now we have a nice smoothly moving hip without any pain and irritation from that deterioration. Afterwards, patients may have a drain with what is called an orthopat or a cell saver, which can collect the bloody drainage from that operative site, separate it from debris and keep the red blood cells, and reinfuse it back into the patient. They can have their own blood that they have donated prior to surgery, autologous blood transfusions. They may have a PCA pump or an epidural pump for pain control, but with the issues with opioid addiction in many cases, and improvements in the actual procedure itself, many patients are controlled with their pain using gabapentin and Tylenol. Positioning for this patient, they need to keep their hips abducted at all times, so spread apart. So they will have an abduction pillow, a kind of a triangular pillow, which keeps them from crossing their operative leg across midline. That can cause the prosthesis to pop out while it is trying to heal. Once it is healed, then they will not have these types of precautions any longer. We want to avoid Hip flexion beyond 90 degrees, again, that can cause the prosthesis to dislodge. So they should have an elevated toilet seat. They should be sitting in a high-backed chair where they're not sinking down into a couch, for example, and having that hip flexed greater than 90 degrees. We're going to do prophylactic antibiotics. We will probably do a prophylaxis for DVTs because this is a long surgery. Patients are immobile and are at risk for developing DVTs. Total knee replacements. So here is your normal knee, your normal tibial plateau, and your normal femoral condyles. And oftentimes through impact, degenerative joint disease, osteoarthritis, these femoral condyles wear away, the tibial plateau and the cartilages and everything become worn down, and then we end up with bone on bone. So similar to those patients with hip replacements, pain not responding to conservative treatment, decreased knee function, inability to work, sleep, walk more than 3 blocks due to pain, loose knee prosthesis from a previous knee replacement, and some knee fractures. Now, in many cases, what they will probably do with patients prior to being approved for the replacement surgery, cortisone injections for the pain. And then something called viscosupplementation, VISCO supplementation, otherwise known as gel injections. And it's a hyaluronic acid type of gel. It's a naturally occurring lubricant, and it's injected directly into the knee joint. It can be injected in one big injection or 3 weekly injections. And what it does is it creates an artificial cushioning for that knee joint. It can delay or even eliminate the need for joint replacement surgery. It worked very, very well on my knee. After I had a meniscus repair, they did the gel injections, and that was about 8 years ago. I've had a couple of courses of gel injections since then. Losing a significant amount of weight really helped. It still bothers me a little bit. I may contact the ortho and see if I can get some injections again, but I certainly don't want to go through a knee replacement if I don't have to. The procedure is where they shave the head of the tibia, they smooth out the distal end of the femur, and then put in a new tibial plateau and a new covering for what used to be your femoral condyles. And now you have a nice, smoothly moving, pain-free knee joint. This is an excellent video that gives you an idea of what they refer to as minimally invasive. There are some more, even less invasive than that, but it's kind of an interesting video to get a glimpse of what your patients go through when they have total knees, so feel free to click on that and watch it. There is a less invasive knee procedure where they use a Stryker navigation system. This is something they've been using at Bay State for quite a while. They call it a GPS for knee replacements, and they put tracking devices attached to your leg bones, and then they go on a monitor, and they can better align the prosthesis and the femur to the tibial plateau without with much less of a invasive type of situation. In the video that you just watched, they talk about intermedullary rods for stabilization and alignment, and this kind of negates the need for that. The benefits are it's a quicker surgery, it is a better aligned surgery, and causes less side effects and a quicker recovery than a traditional knee replacement. So for our aftercare, they may have a drain to an orthopat, they may have a blood transfusion, they may have a PCA or epidural for pain, or they may have the gabapentin and Tylenol. They may have what is called a CPM machine, a continuous passive motion machine, where their leg is consistently and constantly being flexed and extended, so that the prosthesis doesn't freeze up. and they will gradually increase the angle of flexion until the patient hits preferably a 90-degree flexion capability. We will do prophylactic antibiotics and also DVT prophylaxis. So let's move to amputations. There are types of amputations: surgical, intended, or traumatic. Levels of amputation, if it is AKA above the knee, BKA below the knee. We could have the amputation of a toe or a transmetatarsal across the instep of the foot. And our assessment after a patient has had an amputation, we want to check the incision, obviously, for healing. We want to check for the color of the skin. It should be pink and warm, but not bright red and hot. We don't want it to be pale or cyanotic or dark, which could indicate poor circulation to that amputation site. Many patients who have amputations, it's because of either peripheral vascular disease or diabetic neuropathies. So circulation is a problem for them to begin with. So we really have to be very careful to be watching the healing of these amputated limbs. Complications can be your usual ones that you learned about in peri-op and nursing 110, hemorrhage, infection, the problems associated with immobility post-op. But we can also get something called phantom limb pain, which I'll talk about in a second. We can have neuromas, where there's like small tumors, nerve-generated tumors, or flexion contractures, where we haven't positioned the patient and made sure that the joint is fully extended so that it doesn't become contracted. So exercises, range of motion exercises, are key to prevent hip or knee flexion contractures. Think of somebody who's maybe had a below-the-knee amputation, so they have a stump below their knee. If they're sitting up in a wheelchair for hours and hours and hours on end, where their knee is at the edge of the wheelchair seat and their stump is kind of hanging over it, that knee can get stiff and the muscles can they're stiff and they can be contracted, and then they're not able to fully extend that leg, and it will be more difficult to fit them for a prosthesis and get them ambulating as best as possible. Positioning, if they've had an above-the-knee amputation, see if they can tolerate lying prone periodically so that it stretches those muscles in the front of their hips so that they don't get a contracture. The goal is to always get them to the point where they can be fitted for a prosthesis if that's appropriate, and get them up and walking. So we want to keep good range of motion for all the remaining joints that the patient has on their limb. Phantom limb pain is where the patient has feelings of pain or a twisting or contorted or misaligned limb that's no longer there. So it's essentially what's happening is that the brain is sending signals and receiving signals to a part of the body that doesn't exist anymore. And it takes a while sometimes for that to normalize for that patient. Some patients have more issues with phantom limb pain than others. Your PowerPoint's notes pages talk about a lot of medicinal and non-medicinal ways of dealing with and preventing phantom limb pain. So you can refer to that if you are interested in getting any more of that information. And the last thing we're going to talk about are a couple of common orthopedic procedures: the meniscus repair, which is in the knee, and rotator cuff repair, which is the shoulder. I've attached a video that shows both of them in procedures in succession. And our key for both of these is to be looking at our CMS, our circulation, motion, sensation, our neurovascular status, to make sure that we have good pulses, we have good color, we don't have any numbness and tingling. With rotator cuff, we want to make sure that they are in an immobilizer, so we're checking radial pulses and capillary refill to make sure that they have good circulation. and then progressive physical therapy once it is appropriate for that patient's recovery. The rest of the slideshow, which you can find on Canvas, has some practice questions for orthopedic and joint diagnoses.